Great. Thank you. I just want to make sure that's clear. Good morning, everybody, and thank you so much for coming to my talk. I am Dr. Heather Pannetti, a licensed acupuncturist and USA National Board Certified acupuncturist and herbalist. I'm also a massage therapist with over a decade of background in manual therapy. I have a private practice and also am an academic faculty at Pacific College of Health and Science. Let's get into the talk. Are you guys ready to improve your patient outcomes with only 1 to 10 minutes of added manual touch? That's where we're going next. So, four sham controlled trials from independent research groups have confirmed this evidence. And so, what I'm going to do is I'm going to walk you through the research. I apologize. Um, I'm going to walk you through the research, and then I'm also going to credit the data while teaching you guys this technique. So, some of you may already know it. We're all coming from different backgrounds, but I wanted to tailor this presentation that no matter what your patient care expertise is, you can target this technique to enhance your patient outcomes. And so these studies all converged on the same finding that intentional suboccipital manual therapy produces a measurable reproducible parasympathetic activation. And it's not just verified by patient reports, not just clinical impressions. They studied the same thing, heart rate variability, which can be a standard tool for quantifying the autonomic tone and variation between heartbeats. So when parasympathetic activity increases, our heart rate variability also increases. So what we're looking at is a post-intervention heart rate variability data and a real-time readout of what the nervous system is doing, something that we can utilize in our care. These studies all use this as their primary outcome measure. The vagus nerve panel on the left tells you why the anatomy makes this plausible. We're about to get into that in a moment, but what I want you to hold on to right now is this. We're not just talking about relaxation from a general clinical impression. We're talking about technique-specific, mechanically grounded, objective measured parasympathetic responses. So, as I'm sure all of us know, the basic autonomic nervous system. This is just a friendly reminder here. So we are on the same common language, whatever our focus is clinically. As we know, the sympathetic state, fight or flight, but it's not pathological in acute states. It's only pathological when we have excess cortisol. And I thank the previous presenter because she did a great job at getting us all prepped and thinking about the nervous system. So when we have a healthy nervous system, sympathetic state regulates between parasympathetic activity in a really grounded manner as we need it to. So, what we're seeing today, I'm sure, in most of what we see in a highly cortisol involved world, is a lot of people going in a excess state of that sympathetic activity, which means we're not getting the proper function from our parasympathetic state, which is ruled by the vagus nerve. If cortisol is elevated, the immune system surveillance is staying suppressed, tissue repair stays offline, and the body perpetually is preparing for a threat that's not there. We want to get our patients back into rest, repair, immune regulation, and digestion. And we know that if we can activate this cranial nerve 10, vagus nerve, that we can access this influence to regulate the nervous system. And this can all be done through manual contact. Next, I want to look at the anatomy. So, to activate this technique, we're looking at the muscles here. So I want you to pay attention to these suboccipital muscles. This is showing exactly why your hands work where they do when I get into these techniques. The posterior skull, we're seeing the C1 and C2 vertebrae at the suboccipital musculature sitting directly beneath the occiput. The key anatomical fact on the right panel is that cranial nerve 9, 10, and 11 all exit the skull at this jugular foramen. This is between the occiput and the temporal bone. This is not deep or inaccessible structure. It's just beneath the layer of muscle. It's at the depth of your fingertips that you can naturally reach when you cup the base of the skull. The second panel tells you that the clinical consequence when these muscles are hypertonic, and in chronically stressed patients, they almost always are. The mechanical pressure on the exit point reduces our vagal fiber conduction. We don't need a dramatic compression when we're doing these techniques. We need to address the chronic fascial drag along the vagal canal, and doing this is enough to suppress the heart rate variability measurably, excuse me. Everything I'm about to show you in your next few slides is designed to decompress this one structure and restore normal vagal output, and the anatomy is the mechanism. So now we can get into how do we do this? This is the primary technique I want you to leave with today. And I'm happy to share these slides again because I know we have a limited amount of time, so I don't have the full amount of time for everybody to memorize everything on these slides, but it's very simple. Patient supine, practitioner is sitting at the head of the table. You can also activate this from a prone position, but for the intensive purposes of this presentation, the patient is supine. So the patient has a neutral cervical spine. We want to minimize auditory and visual stimulation. I will later also talk about how you can gently guide to activate the parasympathetic state with light auditory stimulation. But for this slide, we want to talk about the hand placements and understand that. So you can use either your thenar eminence or your fingertips to contact the lateral squamous occiput and medial to the mastoid, directly over the occipitomastoid suture and the suboccipital musculature. Your contact weight is light, approximately body weight, 5 grams, the weight of a nickel. You're not firmly pressing, you're allowing your fingertips to listen, to tune in to this space so you can feel what's going on. You're going to apply gentle, sustained upward traction, not active manipulation. What you're doing is decompressing this occipital region and the junction and reducing the mechanical load on the jugular foramen, giving these vagal fibers room to function without compression. What you feel as the technique works, these suboccipital muscles are going to soften under your hands, the tissue will unwind, and there may be a direction of ease that emerges. Rhythmic pulses change quality, and you'll notice patients sigh. Their parasympathetic state is activated. This is not just relaxation as a metaphor, it is a notable sign that the vagus nerve is activated and you are watching their nervous system shift. You will hold until the release is felt, release slowly, allow 1 to 2 minutes of supine rest, and then you can check for measurable data, the post heart rate measurability to verify your data that this is your objective marker for documentation purposes. Now, here's a visual. I know in body work and manual therapy, a lot of us are visual learners. So this is showing you exactly one way an occipital hold can be targeted in practice. As you can see, those fingertips are pointed straight up, and it is allowing gravity to do the work. So the patient is, again, sort of fully supine, spine is neutral. You're allowing the gravity to work with this. All of these things I covered in the previous slide, and since we're limited on time, I'm not going to spend too much time on it. I just wanted to give you guys a visual aid. Next thing we're getting into is our review of the cranial nerve. So the vagus nerve, as we know, is the longest cranial nerve in the body, and it originates in the brainstem and is the first point of vulnerability to mechanical impingement at the jugular foramen, the opening between the occiput and the temporal bone. This is where cranial nerves 9, 10, and 11 all exit together. At that exit point, the vagus descends to innervate the heart, the GI tract. 80% of these fibers are afferent, carrying sensory information from the body to the brain, and 20% are efferent. I'm sure you're all clinicians. I know you know your anatomy, but it's just helpful to remember the clinical relevance. So now as we look at the right column, We understand that the jugular foramen is immediately boarding this occipitomastoid suture and now the suboccipital musculature. Hypertonicity of these muscles and auricular restriction at the occipital atlanta junction creates mechanical pressure on the vagal fibers at that exit point. The nerve doesn't have to be compressed dramatically to have its output reduced. Even mild chronic fascial dragging along the vagal canal is enough to suppress the heart rate variability systematically. The clinical implication is significant. One precise access point at the base of the skull with the whole body within autonomic reach. The research we're about to look at is built exactly on this anatomical presence. So, I don't know if any of you guys have studied craniosacral therapy or osteopathic techniques, but this is referencing that of a still point, the compression of the fourth ventricle. Again, you can use your hand, the inner eminence, to contact the lateral angles of the squamous occiput, slightly medial to the widest point. Through this, this is the same mechanism, same intention with another mechanism to approach it. So this still point is tuning into the cerebrospinal rhythm, the cranial sacral rhythm that you'll feel underneath, and it takes between 1 minute to 90 seconds. When you feel shifts, it can be argued that it's fascia that you're feeling underneath your fingertips. But once you start to feel the change of tissue under your fingertips, you can allow that to guide you, pausing and repeating the technique as needed. So the total treatment can be repeated usually around 3 times for that one still point. Here is a study that I am referencing regarding that previous technique, and this was in regard to a systematic review and meta-analysis that was done in July 2024 that pulled 3 randomized controlled trials measuring heart rate variability after and before craniosacral treatment. There was high frequency and low frequency as the primary outcome measures. The findings are of the heart rate variability power is what we care about. This established objective marker of vagal and parasympathetic tone. It tracks respiratory sinus arrhythmia and is driven specifically by parasympathetic activity. The pooled analysis showed statistical significance increase in heart high frequency power followed by craniosacral therapy with standardized mean difference negative 0.46 indicating post-treatment was higher than the baseline and a 90%, 95% confidence interval, negative 0.79 to negative 0.14. So the standard mean difference falls in the small to medium range. The authors characterize the clinical evidence as moderate short-term increase in parasympathetic activity, which is accurate and clinically meaningful, particularly given this is a single session they studied. The OF finding is extremely equally important and reported to correctly that lower frequency power, which reflects mixed sympathetic and parasympathetic input, didn't have the same significance as the other power did. This tells us that the effect in parasympathetic specific and that it's not a generalized autonomic activation for both the sympathetic as well. So we saw more parasympathetic activity with that in conclusion. One transparency note worth noting in this was this meta-analysis pulled 3 studies. The authors call for further studies because, as we know, with some of the holistic practices and manual therapies, the data is limited. And next slide, I will go into the occipitomastoid suture normalization, direct vagal access. Frontiers in Neuroscience in 2023 targeted trials of this literature because it isolates this single anatomical structure, the occipitomastoid suture, and asked whether normalizing it specifically changes vagal tone. So this study is done on 30 healthy subjects, randomized to the manipulation or sham, and each patient had 10 minutes of treatment. The primary outcome was that we saw a root mean square of successful differences, the primary time domain marker of vagal tone. It reflects beat to beat variation driven specifically by parasympathetic activity. The result increased significantly more in the stimulated osteomastoid suture group than the sham at 8.1 milliseconds versus 2.8 milliseconds. And the p-value was 0.03. This shows you that the sham group did have a small increase, which we can also expect from any supine rest. But the statistical significance group by time interaction proves that this activation of the occipitomastoid suture produced a significant vagal response above and beyond baseline effect. So why does this suture matter? It is the immediate border of your jugular foramen, and restricted mobility here compresses again these three nerves at their exit point. So clinically, tension at the suture has been associated with GI complaints, fatigue, dysphagia, cardiac irregularity, all of which map to vagal disruption. And so 10 minutes of targetized normalization, non-invasive, easily can be added to any of your patient sessions for improved results. So, what are we feeling at contact? You're palpating to feel your hands on instruments. So, listening is a tool with our fingertips. And so, whatever background you come with, the more you touch the body, the more your body attunes to feeling through your fingertips. And so, this slide is about developing your hands as diagnostic instruments to listen through them, not just therapeutic ones. What you feel at the initial contact of the hold, that is going to tell you where to go and what to expect. The hypertonicity of the suboccipital muscles, the rectus capitis posterior and obliquus capitis, these are your most common findings. These muscles sit directly over cranial nerve 10 and exit their contraction creates a compressive load on the vagal fibers. You can feel this as a general firmness, a resistance, and to any direction of ease. Bony resistance at the OA junction indicates auricular restriction, an impingement at the jugular foramen. Fascial drag is your directional guide. Where the tissue leads, that's where compression lives. Follow it, and confirming the evidence, tissue softens under your hands. That's your primary release sign. You can also check the heart rate variability, pay attention to the size as we've talked about in previous slides. Another study, I'm being mindful of time, so I might not talk about all the data with every slide study. I'll try to summarize as much as possible, but this was also studying the quantitative relationship between osteopathic manipulation and sympathetic vagal balance. So the shift was strong enough to overcome experimentally imposed sympathetic dominance. Touch alone was not significant or sufficient. This specific technique was what produced the effect of pulling at the OA. So this can be measured for understanding that while maintaining the heart rate variability change is specific to this tilt, the tilt study during the baseline versus the manual manipulation. So cervical myofascial created an autonomic response that was not mimicked when just casual touch was applied. So we can look at this for any of our patients in a state of extreme tension or even just those who can't turn off. This is another study that supported that head cradling can also show a significant improvement in the randomized, I'm sorry, the results showed that the deep touch versus the TMJ conditions was stronger with this head cradling technique, and that the joint work did not replicate this effect. So they were studying the difference between TMJ mobilization or passive rest, and neither of those posi positions showed the significant heart rate variability change. And from the suboccipital literature this time, this is a completely different research group, using a different protocol. It showed that we did see the same benefit affecting the heart rate variability through the head cradling technique versus these other two studied and compared trials. So another thing that I wanted to get into, how can we also support our patient through verbal cues? So oftentimes when I'm starting this hold for releasing the occiput to activate the parasympathetic state, yes, that can be enough. There's also studies and evidence to show that guiding patients through low frequency speaking into verbal cues can also activate that parasympathetic state. And so I've provided here with some suggested language, and there's a study that also is cited underneath supporting that this communication can help to activate the vagal tone and circuit and regarding to the body to activate the parasympathetic state. And so oftentimes when I'm doing this for a patient, I will guide them with a breath of take a deep breath, exhale fully, longer than you inhale. That breathing out longer than the inhale is key because they're exhaling longer than the inhale is where we're going to see that shift in the parasympathetic state. It gets us out of fight or flight and it gets that shift. And so lowering my tone, guiding the patient to safety cues of there's nothing to do, there's nowhere to be, allow yourself to deepen. So now we're going to go into everything neurophysiologically consistent with vagal engagement. So these are all the signs we can look at through the breathing slows, as we've mentioned, cardiac signs that we can test the pulse, feel the palpation to see is that reduced. You can see from a musculoskeletal perspective, the shoulders are dropping, the jaw unclenches. All of these muscles are going to soften palpably under your hands. Patients may have eye fluttering or close without effort or report feeling heavy or sinking. You can also have them mention reduced pain or comment on it. You can document this in your patient outcomes based on the sighing, the heart rate change, tissue softening, and you can also pre and post pain rating and measure the heart rate variability if available. So you can add this to any session, and usually I'll start most of my sessions this way. Occipital hold, let's tune out. So patient arrives after you've done your intake, however you want to do it, taking that moment, 1 to 2 minutes, to just set the frame for this. I sometimes will do it before needling when I'm doing acupuncture, sometimes after, depending on where the needles are going. You can also do it mid-session, depending on your scope, even with, as long as there's consent to touch, you can apply these techniques or closing the session. The goal is to balance the autonomic nervous system and allow your patient that space of tuning back in to their parasympathetic state. The last couple slides are more evidence further supporting that these osteopathic manipulations show significant evidence to manual therapy, balancing the nervous system, and the heart rate variability was measured in these studies. Again, anybody who wants these slides, I'll allow them, but I'm not going to spend too much time on them because I know I'm getting close to time. So again, we have our last slide here that findings are credible in clinical research, and it's not just one strong trial. It's replicated across independent groups using different protocols with different populations, but all targeting the occipital mastoid suture to find that these independent research groups with different techniques and different outcome measures and even different patient populations, they all pointed to the same direction. The convergence is what gives this evidence to this technique the results. So we see that through this manipulation of the occiput to activate this, we're getting the achieved result, which is a regulated nervous system in our patients to achieve their patient outcomes. Again, one more study, and I have these summarized for you guys. I know I'm out of time, so I'm going to get back into the conclusion. I want you guys to take away with from this study. So I really want from this presentation, my goal is that you take away these 5 points, that you remember the importance of the vagus nerve exiting at the jugular foramen, that it's directly accessible through intentional suboccipital manual contact, that you remember how to feel for the hypertonicity and articular restriction at the site so that you can help your patients suppress their heart rate variability and regulate their nervous system. This technique specificity does matter, and general touch just doesn't replace this. So it's important to tune in, learn how to palpate, and trust that it's working. And additionally, if you're having trouble, the verbal safety cues can also help. And there are studies to support this evidence. It's not just suggestive. Any questions? And here are the study references. I'm happy to take any questions if anybody is curious about more.